Dr. Manisha Dassi is not here. I think I request Dr. Kuldeep Dhar to kindly come and chair the session. He is the treasurer of API Noida chapter. Dr. Kuldeep Dhar.
So next session is a very interesting topic again. None other than Dr. Vijay Kher, and he would be speaking on infections in kidney transplant patients. And after that, an enlightening lecture by Dr. S.C. Chabra. I think the stage is set for Dr. Vijay Kher. Of course, everybody knows Dr. Vijay Kher. He is currently the chairman and of the Division of Nephrology and Transplant Medicine at Epitome Kidney and Urology Institute in New Delhi. And he has, of course, a huge academic career behind him. So without wasting much time, I will hand it over to Dr. Vijay Kher. Sir.
Thank you, Dr. Makkar, and all the chairpersons on the stage. And I must thank Neeru and the other organizing committee members to invite me again. I've been here many times, Dr. Chabra, who is the father of nephrology in this region, and he used to call me, but most often I used to dread is usually the late sessions that used to run in this. But I must congratulate them that today is all on time. So without wasting time, let me talk about the talk given to me, and that's about infections in the kidney transplant recipients. And Dr. Chabra has said that kidney transplantation is the best and the most cost-effective treatment for end-stage kidney disease. So compared to dialysis, transplantation is much better, both in terms of outcomes, in terms of cost, and including the quality of life. And he was also talking about 1 year survival of more than 95% currently with transplantation. Dialysis, 1 year survival is about, whether it is peritoneal dialysis or hemodialysis, would be about 80% or so. 5 year transplantation survival is about more than 90% now. About living donor transplants, even more than 95% now. And 10 year survival of about 80 to 85%. So, in comparison, dialysis, 10 year survival in dialysis is about 20 to 30%. So most patients of dialysis will die of cardiovascular disease. And if you look at this survival is even less than the survival of many cancer patients. So we haven't evolved yet in the technology of dialysis in such manner that we provide only 10 to 15% additional kidney function to a patient with end-stage kidney disease with dialysis, whereas transplantation will replace almost whole functions of the kidney. So transplantation is better. The only time where transplantation does poorly as far as survival is concerned is the first 3 months of transplantation, where mortality is higher than dialysis, but every point after that, transplantation is much superior as far as outcomes are concerned. So the survival of patients on transplantation is, so younger patients definitely, as physicians, I would say that you must push these patients to go for transplantation because the outcomes of transplantation are much better in these patients. This is the cost of transplantation. I had calculated it sometimes earlier, way in 2002. This was, even currently, the 1 year cost of transplantation in most centers would be about 7 to 9 lakhs of rupees. 1 year, 1 lakh rupees is the cost of immunosuppression, maybe 1.5 in the first year, but usually about 1 lakh by the second year or so. And therefore, preventing infections in transplant patients is an important parameter, and I think I would spend the next 15-20 minutes on that. How do we prevent and how do we so infections remain the commonest cause of death in a transplant recipient in this country. And what determines this is usually the net state of immunosuppressive. These patients receive lifelong immunosuppressive drugs, and therefore to keep that transplantation away from rejections, so there is a price which one has to pay from chronic long-term immunosuppression, and that is what is the infections and is the epidemiological exposure of these patients to that. So what kind of exposures they get. The epidemiological exposures could be, the infections could come from the donor kidney, cytomegalovirus, CMV, IgG positive patient into a young child who is CMV negative, he will develop, or Epstein-Barr virus, he will develop Epstein-Barr virus if it is negative in the donor, in the recipient. So these are some of the infections. Tuberculosis in the donor sometimes can be transplanted. Malignancies can be transplanted with the donors and all those. So recipient-derived infections, the natural bacteriological strata of the recipients can predispose them to a kind of infection. Community-acquired infections, pneumonias and bacterial infections or even fungal infections. And then they are in the hospital and obviously can acquire nosocomial infections as such. What is the net state of immune deficiency? That is the current and the previous immunosuppressive drugs that these have received. And I think I would say one thing, what is important is that many nephrologists as well as physicians who take care of these transplant or patients, prior immunosuppression is important. And if there is a patient, I am imploring that you should put your patients of chronic kidney disease for transplantation. If many of these patients have had glomerulonephritis, we do biopsies. Dr. Satish talked about late referral to nephrologist. These patients come when they are already, kidneys are end-stage kidney disease. We biopsy them many times. IgA stage 4-5, glomerulonephritis stage 4-5, but we continue to give them immunosuppression, trying to save the kidney. But if this patient is going to go for transplantation, I would cut down, because transplant is ultimately, that is what going to. And the outcomes of these patients who have previously not received immunosuppression will do much better. Those who have already received immunosuppression for trying to save these end-stage kidney disease will develop infections in the post-transplant period. So trying to prevent the prior therapies of chemotherapy or these immunosuppressive therapies is then extremely important, and this must be taken in the overall context of the management of these patients. When you look at these patients, especially young patients who are likely to undergo kidney transplantation. Then malnutrition is another thing which happens in our patients. We give them keto analogs, prevent protein intake in patients of our chronic kidney disease. You see these patients are lean and thin. Whether you do dialysis on them or you do transplant on them, they will die. They will develop an infection and they will die. So prevent malnutrition in your chronic kidney disease patients prior to transplantation. Don't give them reasonably good protein diet. Indians are taking as such very low protein diet. So there is no need for protein restriction in chronic kidney disease. Please remove this. Protein restriction in chronic kidney disease in India leads to malnutrition. That's an important point that you must remember. Don't allow these patients to go. You are the physicians who see them, and you are the ones who can influence their thinking and thought process. So don't do low protein diets in these patients. And then obviously other viral infections, CMV viruses which are present in our body, BK virus disease, these can get aggravated whenever net immunosuppression is higher. So the treatment as well as management of these is sort of keeping the immunosuppression in such way so that you decide that there is an optimal immunosuppression given to your patients. Transplant patients, because they are on immunosuppression, also have less inflammatory response. So therefore, the symptoms, typical symptoms of signs of infection are not present in these patients. Tuberculosis is usually pulmonary in non-transplant or non-kidney disease patients. Tuberculosis in transplant recipients is extrapulmonary, hidden. You will have to dig in to make a diagnosis of tuberculosis, definitive diagnosis of tuberculosis in these patients. So the regular signs and symptoms of infection are, so there is even the radiological tests and the serological tests also might get altered because of the immunosuppression. And These patients, if they get mild, they are very good today. You feel that this is okay, you can manage them outpatient, but within 24 hours, they can deteriorate very, very rapidly. So be cautious of transplant recipients, even with mild infections. So you must make a diagnosis, definitive diagnosis quickly, and must treat them effectively. Many of these drugs can create problems. Like you have patients with tuberculosis, you can't give them rifampicin because rifampicin has an effect on tacrolimus and cyclosporin, CNIs. It decreases the levels and will cause an acute rejection if you use this. Erythromycin increases the levels of tacrolimus or cyclosporin. So therefore, giving erythromycin, which seems very non-toxic kind of a drug, to a patient will increase their levels and cause severe CNI toxicity. Then there can be other drugs which are nephrotoxic, like aminoglycosides, amphotericin B, high dose of cotrimoxazole, usually used for treatment of pneumocystis carinii. They can all create associations. So you must be aware of all these associations. Who are people who will be at low risk of infections? Those who have good matches. If full house match, brother or a sister is a donor, you don't need to give that much of immunosuppression, no induction therapy. Very good surgery. If the graft function is good. So if you don't get into complications, and fortunately, these days I can tell you with current immunological tests, if a physician is careful, if your surgeon is good, your matches are reasonably taken care of by immunosuppression, you can optimize immunosuppression based, individualized on a particular patient, depending on how much immunological risk that patient has, you might be able to prevent infections in these patients. Appropriate surgical prophylaxis, not giving too many antibiotics, but giving an appropriate dose of prophylaxis in these patients, giving antiviral prophylaxis. So CMV prophylaxis would be required. Prophylaxis for pneumocystis carinii like cotrimoxazole would be required. So these prevent infections in the post-transplant. And vaccinations. Adult vaccination is a neglected field in India. And physicians should be, this is a physicians forum, so physicians should be the ones who should start asking every patient of yours for age-appropriate vaccinations. And in pediatrics, we do vaccinations, but adult vaccination is a neglected, totally neglected area. No one talks about it. And as nephrologists, I would say that all kidney disease patients, cardiovascular disease patients, liver disease patients, they must be vaccinated. And age-appropriate vaccinations for pneumonia, flu, shingles, and many other vaccinations. Hepatitis B is very, very highly prevalent in kidney disease patients, so we must immunize them appropriately. There is an infection pattern in the first 3 months. Usually patients are in the hospital for some period of time. So usually bacterial infections, surgical infections are common. Urinary tract infection is the #1 reason for infections during, or donor-derived infections, like CMV in a patient, in a donor who is positive, if we haven't given prophylaxis, will develop cytomegalovirus infection. So these are viruses which, or bacteria which are there in the first months. 1 to 6 months usually cytomegalovirus, BK virus, pneumocystis carinii, or community-acquired fungal infections or urinary tract infection. Tuberculosis in our country is very, very common. 10 times commoner than in the general population. So patients with kidney transplant are at a very high risk of developing tuberculosis. And tuberculosis is common in our country, so one of the commonest causes of post-transplant infections. And beyond 6 months, you will get many opportunistic infections, especially fungal infections. They're very common, nocardiosis, tuberculosis, urinary tract infections. These remain as well. So there is a time frame during which the infections occur, and this time frame might change from place to place depending on what kind of bacterial flora in your hospital or around you are there. Those would determine what kind of infections will happen in these patients. So the common infections which a transplant patient is seen is the bacterial infections and urinary tract infections in the first month or first 3 months. Now, asymptomatic bacteriuria during early diseases of kidney disease, and as a physician again, another point which I would say asymptomatic bacteriuria, please don't treat it. There are only two conditions when you have to treat asymptomatic bacteriuria. Asymptomatic bacteria during pregnancy and when you are doing a urological procedure. No other condition, medical condition, no other medical condition. I'm making very emphatic statement. No other medical condition deserves treatment of asymptomatic bacteriuria. But I see prescriptions loaded not only with routine antibiotics, aminoglycosides, cephalosporins intravenously being given for asymptomatic bacteriuria. And same is for transplant patients also. There was a fear that first 3 months prophylaxis for urinary tract infection must be given, but now there is reasonable enough evidence that there is no need to treat asymptomatic bacteriuria even in the transplant recipients. So there is symptomatic UTI, yes, that needs effective treatment. Pneumonia, tuberculosis, nocardiosis. Infections can be together. You might find tuberculosis, but don't neglect that if there is a lesion somewhere else and you find that that could be something else, it's very common in transplant patients to have two infections, CMV and tuberculosis, CMV and fungal tuberculosis and nocardiosis. Not common. So you don't get satisfied that you have one infection, therefore you have found out what the cause of fever is, he may have another infection, co-infection in these patients. So that's again fairly common in these patients. Candida, aspergillosis, mucormycosis, cryptococcal meningitis, histoplasmosis. These are other fungal infections which are fairly common. Usually fungal infections may be given Candida for Candida. Candida is the number one fungal infection in the post-transplant period. So usually Candida prophylaxis, the fungal prophylaxis for Candida is given for about first 2 months or so in the post-transplant period. But otherwise, cotrimoxazole for pneumocystis carinea is given for 6 months to maybe a year also in some transplant units. Cytomegalovirus infection prophylaxis with Valgan cyclovir is given for about 3 months post-transplantation these days currently to prevent infections. But whenever you are treating acute rejections and all, these prophylaxis must be done. These must be done also when you are treating patients with glomerulonephritis, which is not being done currently in most patients. Most of the viruses which you come, suddenly these patients come with cytomegalovirus, could be associated with pneumonia, could be associated with fever, leukopenias, could be liver dysfunction, could be gastroenteritis, acute gastroenteritis. And it's very important that CMV IgM, which is commonly used as a diagnostic, be banned. It has no relevance at all. You have CMV PCR available now, which has a better sensitivity and specificity for cytomegalovirus. So stop using tests which are not going to give you any information. It wastes time. So use cytomegalovirus PCR for diagnosis. And in patients who have gastroenteritis, you will have to do a biopsy because serological tests, even CMV PCR may be negative in these patients. So therefore, you would ask the person who is doing the endoscopies to take biopsies from them to make a diagnosis of cytomegalovirus. Otherwise, you will miss these diagnoses. BK virus must be looked at in the post-transplant period because this is a common cause of dysfunction. It doesn't produce systemic symptoms. It is just kidney dysfunction. So anyone who gets a kidney dysfunction in the post-transplant period, look for BK virus nephropathy in addition to in rejection. Parvovirus, a virus which is again sudden decrease in hemoglobin post-transplant period. Somebody who had a hemoglobin of 15 comes with a hemoglobin of 5, parvovirus. Look of that, just decrease immunosuppression. These are cries of the body that you are giving me too much immunosuppression. Reduce the immunosuppression, these viruses go away without needing, except for cytomegalovirus, it can be very serious and all. Parvovirus and BK virus, just reduce immunosuppression and they get better. If they don't get better, then intravenous immunoglobulin could be given in these patients. But otherwise, usually they get. Herpes zoster, you can prevent these days by shingles vaccine. Herpes simplex, these are can be very clinical problems. Sometimes they get systemic warts. You have warts everywhere in the body. Just change the immunosuppression or decrease immunosuppression or give them a drug called everolimus. You will see they will disappear. Change mycophenolate to everolimus and you will have warts disappearing from the body all of a sudden in these patients. So the characteristics which I would again emphasize, you will have multiple infections in patients. I talked about it earlier. Again say, typical signs and symptoms of infections are usually lacking in transplant patients. So be on the lookout for infection and make diagnosis. Specific diagnosis is extremely important. I can tell you, I can give you a story. We were working in Sanjay Gandhi Postgraduate Institute. It was a highly super specialized institute. We didn't have pulmonary department with us. So right in our eyes, many patients with pneumonia would die because we were not able to make a diagnosis because we didn't have a pulmonologist who would do a bronchoscopy or do a lung biopsy. So it was frustrating to see all these patients die right under your nose. You would give them, like these days also many times, if you don't want to make a diagnosis, you keep on giving them antibacterial, one antibiotic, then second and third, then anti-tubercular, then antifungal drugs and all that. So you give everything to them. You will never be able to save these patients, I can tell you. Unless you make a specific diagnosis, giving them all kinds of therapies will not save these patients. So I convinced the cardiothoracic surgeon, young cardiothoracic surgeon, to do lung biopsies. These are very sick patients. Often clinicians would refuse to do biopsies on these very sick patients. But I can tell you, I convinced him. I told him, you be on my shoulder, I'm giving you my shoulder. We did it. All the patients we did open biopsies in this, we made the diagnosis, everyone survived. So making a specific diagnosis is extremely important. Giving them empirical drugs is not at all important. So always go invasive, make a histological diagnosis, make a bacteriological diagnosis, make a very highly specific and sensitive immunological test, molecular testing, which is becoming better in these days, but you don't have every disease having those kind of things. So those would become the most important things for making diagnosis. Vaccinations I talked about, so please vaccinate your patients. That's the best way of preventing infections. If you vaccinate your patients prior to transplant, because live vaccines cannot be given post-transplantation. So diseases which have live vaccines will have to be given before transplantation, although attenuated vaccinations can be done post-transplantation, but every physician must try to vaccinate these patients if you really want to prevent infections in these patients. There are many other ways I talked about, prophylaxis of infections, and we use usually antifungal prophylaxis in the first 3 months by candid oral paints, or sometimes if the infection is higher, maybe oral fluconazole or so. But pneumocystis carinea usually 3-6 months, maybe a year prophylaxis with cotrimoxazole has been used, and people even have used lifelong cotrimoxazole prophylaxis, but maybe most often usually about 6 months of therapy. And cytomegalovirus, again, these days valganciclovir becoming available, generic ones available, cost having been, now almost all transplant units use. So prevention of infections becomes an important strategy in these patients. How do you manage infections? Well, if you have mild to moderate, then reduce immunosuppression. The usual drug which is reduced is either a metabolite, antimetabolite, mycophenolate mofetil, and if the patients are on azathioprine, then that is reduced. In moderate to severe infections, you might stop them also for some period of time till the infections get better. But if patients are with life-threatening infections, with hypotension in the intensive care unit, about to go on ventilator, then you should stop immunosuppression for these life-saving infections. And then, so stop tacrolimus and mycophenolate. Steroids can be given as an intravenous hydrocortisone for some period of time till they recover from infections. And surprisingly, you find that many patients, even though you have stopped immunosuppression for 2 weeks or so, 3 weeks, when they get better, the kidney function, after you restart them, the kidney function in many of these patients would come back. You will be surprised that yes, during infection, probably the immunosuppression is high, so therefore immunosuppression needs to be stopped for some period of time. So that's a general kind of a management issues in these. So I have some pictures which is not uncommon for you to see, is tuberculosis in these patients, herpes zoster in a transplant patient. This is candida esophagitis on an endoscopy, then cytomegalovirus inclusions, which you can see on a biopsy. This is lung not showing too much, but oxygen saturation going down. pneumocystis carinii, and this you can see a postmortem of a lung which shows severe involvement, and that can happen, and radiologically you don't see. So when you see a patient who is hypoxic, has mild radiological signs, look at pneumocystis carinii. This is aspergillosis, and this is cryptococcal meningitis. So a patient who comes with headache, fever of some duration, in a transplant patient, do think of cryptococcal meningitis. You'll have to do a CSF examination, and this is India Inc. preparation, although these days you have molecular tests also available, so you could make a diagnosis of cryptococcus in these patients. So ladies and gentlemen, I've told you that if you have to manage infections in the post-transplant period, the management of a transplant is a skillful navigation. There is a lot of science available to it, but it is still remains a lot of art in this. How you manage preventing rejection and preventing infection is something which is a seesaw kind of a thing. So it will, over the years, as you grow, you will, in your experience, you will see that you will be able to manage these patients much better. In the earlier times, you will have to err either on one or the other side. You will see most of these. So ladies and gentlemen, let me conclude. Infections remain a common cause of death in kidney transplant recipients. Early, specific diagnosis is essential to successfully treat infections and save life. Often trying to save the kidney, one loses the patient, and that's important. So it is important to save the patient. Survival of patient is much more important than the kidney. He can go back on dialysis, so it's important. So don't try to save the kidney sometimes if they have rejections, because you are likely to kill them by a severe life-threatening infection. So be cautious, which you learn. Patient's life should always take precedence over the kidney, which we sometimes overdo, and we might lose the patient. So these are some of the successful stories of patients. This is a mother who has donated to this young girl, and she's got delivered successful pregnancy. So she was having kidney transplant before she got married, then successfully after marriage had 2 kids as well, and her other daughter also had kidney disease. She also received a kidney transplant, is also successfully married and has children. This is another one, 10-year-old girl who came and we transplanted in Apollo Hospital, and then she is now grown and has a daughter also, so about 20-22 years post-transplantation. Then these young ladies who are very beautiful, who they become now friends also, and they go for lunches. They don't invite me often, but they go for lunches and send me these photographs as well to see that they're enjoying. This is again another patient who was young and got married and has children successfully. This is the same one with an elder daughter who is now in college. And these are 2 transplants who are 35 years. The right one is 35 years post-transplant. The left one is 32 years post-transplant. And they are not on the current therapies. They were on azathioprine, and we haven't changed these therapies ever since then. So they continue to remain well. And so transplantation, despite these complications, is an extremely fruitful exercise and satisfying for the physicians. And thank you very much.
Thank you, Dr. Kher, and as expected, you've delivered yet again a wonderful lecture and clarified a lot of myths, especially for the physician community. And 2 or 3 very emphatic statements that you made. One, of course, is that do not delay the diagnosis. If you're suspecting an infection, go for the diagnosis and try to make a specific diagnosis. I think that's a very emphatic statement. Then, of course, not to treat asymptomatic bacteria in patients unless there are, of course, indications like pregnancy. So I think we are more enlightened as physicians with your talk on how to prevent and treat infections and how to suspect infections in post-transplant patients. I believe if there are more questions from the audience, we can have a few questions. If not, that maybe we can have questions from the co-chairs. Any questions from the audience?
Sir, how many cases those patients who had undergone renal transplant, they had adult immunization done?
How many? Yeah, we try to be, I have been very proactive on vaccinations, and so we tend to vaccinate our patients early. Hepatitis B vaccination should be done in CKD patients very early, because that's one infection which we can prevent, because if you in very early stages, the response and seroconversion rate with vaccinations are fairly high. So doing it later also, but whenever you get the patient, you should vaccinate them. And hepatitis B is one, pneumonia is another vaccines we should be done. And these days now herpes simplex, herpes zoster virus, that should be also done. And you have varicella, which should also be done in these patients. And obviously flu vaccination should be given every year.
Nephritis or CKD. So there is evidence that they should be done much earlier if you can do it, but usually you would do it after 6 months when they
small dose should be used, not necessarily one tablet daily. You could do it once a week or so, because fluconazole also has a sort of a reaction with tacrolimus. It raises the levels of cyanides. So therefore, the dosages will need to be. So we usually avoid using them in the regular doses, but one will have to modify depending on how severe the fungal infections are. I use other than fluconazole drugs.
And regarding tuberculosis, latent tuberculosis being so common in India, what is your strategy to detect latent tuberculosis? And then if you suspect, and how do you treat them? How do you manage them? Is there a prophylactic regimen?
Tuberculosis is something that we treat differently than rest of the world. I can tell you that. Patients of chronic kidney disease prior to transplant, if they have tuberculosis or latent tuberculosis in the Western world, we don't treat. At the moment, at least nephrologists don't treat latent tuberculosis. We don't look for tuberculosis in patients who don't have any symptoms. But those who have been diagnosed with tuberculosis prior to transplantation, usually we don't wait like rest of the world. They will treat completely for 9 months to a year before they take them for transplant. But we usually treat them for 6 to 8 weeks with full therapy, and then once they become asymptomatic, we take them for transplant and continue anti-tubercular treatment. And we have published on this recently on our experience on this. This is in transplantation, and that has shown, because this was needed for the rest of the world, because they would usually not do, because latent tuberculosis in other countries where tuberculosis is not endemic, they will treat the latent tuberculosis prior to transplantation. But in our country, most nephrologists and physicians would usually look for tuberculosis in the post-transplant period and not give any prophylaxis also. There are some units which do use Isonex prophylaxis, but I think it increases the resistance, so we usually don't use prophylaxis.
Yeah, Dr. Gera.
Is everything. What if you have taken hepatitis?
Pardon?
What if you have taken hepatitis C?
Hepatitis C.
Yes,
Hepatitis
it's
C,
a very big
fortunately,
problem.
hepatitis C is a big problem in dialysis population, but hepatitis C is fortunately, now with the new antivirals, you give 3 months of therapy. So we would, if the patient is hepatitis C positive, prior to transplantation, we start 1 month treatment, take them through, and many patients will take them earlier. So fortunately, hepatitis C has become an easier problem to tackle now. Pre and post-transplant, it is easier to give these drugs. They don't have that much of adverse effects in the post-transplant period as well, and so you can continue to use these drugs. Thank you.
So if there are no more questions, thank you once again, Dr. Vijay Kher, for that wonderful talk. Thank you once again.
Request all the faculty and chairpersons to move for felicitation, and I would request Dr. R.K. Gupta to facilitate our. So the next session would be on recent advances